This particular video will be about the reimbursement basics of generating revenue. This week in the course, what we'll be talking about is payer mix, generating revenue, third-party payer system, responsibility regulatory hierarchy, which are the rules of the game, and you'll be taking a reimbursement basics or reimbursement success self-assessment. Let's get started. Payer mix is the relative amount of payment received from a variety of reimbursement resources, including private pay, commercial insurance, governmental payers such as Medicare, Medicaid, and any other sources of payment that are made to a practice for clinical care. It's usually expressed in the form of a pie chart. So typically when you look at payer mix, you'll see pie charts. Now, payer mix can be expressed by the number of patients from each of those sources. It could be expressed by the number of dollars earned. It could be expressed by the number of visits. In this case, this example that we're looking at right here is a payer mix that's by the number of patients. That's not necessarily the most common, but it's the one that we're showing you here. And in this example, you'll see that Medicare is 30% of the number of patients. The payer called Medicare is 30%. Workers' comp is 10. Blue Cross Blue Shield of Michigan is 30. Commercial is 20. Medicaid is 5 and litigation is 5. Now this is just an example. And again, it is using number of patients as the basis for payer mix. Most often you're going to see it as the amount of revenue or the number of visits. As part of your assignment this week, you'll be completing the payer mix analysis worksheet for your top 5 or 6 payers based on volume. So I would encourage you to do that based on visits. And here you want to identify what's the type of practice that you're in. What is the method of payment? For example, a fee schedule, or based on the number of, based on variety of units, or possibly a fee schedule based on visits. How is it that they decide how to pay you? And then what percentage of your total visits of your total business based on the number of visits, in this case, is each one of these? Revenue generation is what a business is about. Typically, it is about providing a service or a product of some sort in exchange for creating revenue. As we talk about revenue generation today, we're going to be talking about types of insurance, primary and secondary. We're going to talk a little bit about cash and patient payments. We're going to talk about being in and out of network, participating and non-participating. We'll talk about some restrictions on the reimbursement system, not all of them, but some of them. We'll talk a little bit about direct access. We'll talk about enrollment, verification, and prior authorizations. And then we'll take look at some examples of specific coding and time frame requirements when it comes to revenue generation. First thing is, insurance is the primary way in which therapy is paid for across the country. Doesn't mean it's the only way, but it is the primary way. And when we look at insurance, we need to identify first the primary insurance, and then if there is one, a secondary insurance. A primary insurance would be that insurance which would be the one that is initially responsible to pay for the care that is provided based on whatever rules and regulations are in play. A secondary insurance is one that would be able to come into play for those things that the primary insurance does not cover. A secondary insurance, when it's, for example, when the primary is Medicare, could be a Medicare supplemental program, or it could be just a secondary insurance. On the screen, you see a screenshot from one of our programs that we use in our companies that takes a look at identifying what is the primary insurance, which should be the first column here, identified primary. In this case, it's Medicare. Here's their contract number. And then the insurance was verified on this date. The secondary insurance, in this case, was Aetna. Here's their contracting group numbers and whatever other information we needed. We like to keep a track of when was the insurance verified and who did it. Additionally, you'll see that there's some notes, some additional insurance information. Medicare, it says down here, Medicare is active. Aetna, which is spelled wrong here, is active. The Aetna plan has a $250 deductible, of which there is $103 remaining. The plan covers 100% of approved services after the deductible is met. Additionally, we have a little area up here in yellow that talks about, is verification needed? And you would check it yes if you wanted it to be, no if it's not. which would be very rare. And in this case, it was done. So that way we're able to keep track of that. So when we talk about insurance, we need to identify the primary and the secondary and understand how both of them play and interact together. An additional way when insurance is not involved is that there will be cash or patient payments for some services. This could be the part of the insurance payment that is referred to as either a copay, which is typically a dollar amount, such as a $5 copay, $10 copay, $20 copay, and that's part of the insurance contract that the patient has purchased. Or it could be a coinsurance, which would be a percentage. So, for example, Medicare pays 80% of the Medicare allowable amounts when the services are provided under the guidelines that meet Medicare rules. The additional 20% was a coinsurance, and that is either paid by a supplemental or secondary insurance, or the patient will pay it themselves. Additionally, there is something called the cash-based practice, and that is a physical therapy practice in which the practice has decided not to participate in any insurance companies, not to interact with them, and the patient will pay for the services and then take a receipt and possibly submit that receipt for reimbursement themselves to the insurance company. What this means is that the patients are now making value decisions based on how they perceive the therapy and what they perceive it to be worth. This is a new phenomenon in the last few years for many, many practices. Although cash-based practices have been around for a long time, it is becoming much more frequent that a percentage of the practice or entire practices are cash-based. It is necessary also to mention here that there is a big difference between deciding to be a cash-based practice and, in essence, becoming one involuntarily in a situation where patients' deductibles are so large that they, in essence, do not have any insurance coverage. The decisions that patients will be making based on their financial situation and their decision about how they want to spend their medical dollars are very complex and certainly is outside the scope of what we're going to talk about in this course. Typically is much more involved in a marketing course where we're now talking about trying to help patients understand the true value of therapy in the settings that they're receiving them. Additionally, we have often gotten questions about, is it possible for physical therapists to opt out of Medicare and not participate in the Medicare program? Physical therapists can choose to not participate in Medicare. However, because Medicare is a federal program and is covered by federal law, we are not one of the health professions as physical therapists that is identified as being able to opt out of Medicare. What that means is that cash-paying patients for Medicare services, cash-paying Medicare patients do not have the option, according to federal Medicare laws, to pay cash. In other words, it has to be billed through the Medicare program, whether we're participating in the program or not. A relatively recent occurrence is the passage of the High-Tech Act, which hopefully you'll have been exposed to in some of the other courses. And there's what we call the secret clause for cash, which says the patients have the ability to direct a therapist or any healthcare provider to not inform the insurance company of services that they are being provided. And in that situation, the patient has the option to pay cash for it. This would allow us to have the patient upfront instead of authorizing payment through Medicare, saying, I authorize you not to, I do not authorize you to contact Medicare, in which case the patient would be able to pay cash for those services and the practice probably would be in compliance. I do want to point out that I'm not a legal expert. I also want to point out that this has not been tested in courts, and I don't know of any pending cases where that's going to be the case. But historically, it's always been the case that physical therapists can't opt out of Medicare. This secret clause for cash and the High-Tech Act is one that a lot of therapists are using to get around that. And if that's attractive to you, we probably could talk about that more out of class. We're going to talk now a little bit about being in and out of network, being participating versus non-participating. And when you are in network with an insurance company, whether it's yourself as an individual therapist, whether it's your practice, or whether it's your organization or healthcare system, there is a provider agreement that is signed. That provider agreement is a contract. The conditions and the terms of that contract are binding by civil law. And it is important that when a provider agreement exists and has been signed, that the therapist needs to follow all the rules of the contract, and the insurance company also has to follow all the rules of the contract. In exchange for that, sometimes, many times, insurance companies will give you what is called preferred status. Now, that may just be a title with no real value, or it could be that patients are being actually directed to your practice as an in-network provider. Now, if you are out of network, there is no contract. And then the requirements would be to follow the legal and professional standards of the jurisdiction and discipline in which you practice. So, for example, I work as a physical therapist in Michigan. If I'm out of network with a private insurance company, I am still required to follow all the Michigan rules, all the federal rules, and the professional standards of the physical therapy profession. However, I have not signed a specific contract that requires me to do additional things as I would if I had a provider agreement. Let's talk a little bit about some of the restrictions on the reimbursement system. The first one is enrollment. And many third-party payers require that before they will reimburse you for services provided, that you have to be enrolled and have provider numbers. Medicare does this, Blue Cross does this, almost all the HMOs do it. And the enrollment process can be quite cumbersome. It's often thought of a very similar way to how we fill out our taxes every year as individuals. There's lots of forms, there's lots of paperwork. The process itself can be a significant barrier to entry into the world of receiving payment for physical therapy. It is not something to be taken trivially. It can be a very daunting process. Within our organization of in-home rehab, we have an enrollment specialist, and that is all that she does, pretty much 40 hours a week, is help new people who are coming into the practice become enrolled. Now, the enrollment requirements vary by the type of setting that you're in. So, for example, if you are facility-based, such as a hospital, a rehab agency, or a CORF, comprehensive outpatient rehab facility, the facility itself is enrolled, and the people who work there are by proxy enrolled. If you are a physical therapist in private practice or occupational therapist in private practice, enrollment is for each individual professional, each license, and for the organization as a whole. Secondly, verification of benefits. One of the restrictions on the reimbursement system is that benefits are sometimes quite convoluted. There's an old saying in the world of Blue Cross: if you've seen the benefits of one Blue Cross plan, you've seen the benefits of one Blue Cross plan. It is not one size fits all. There's lots of variety, and it is necessary to really, for every patient that's coming in, to verify what are the benefits so we understand them, so the patient understands what financial responsibilities they may have, and that we'll also be able to correctly bill the case. In some cases, there's also something called prior authorization for services. Prior authorization for services requires that we contact the insurance company, let them know what our plan of care is and our intent, and then there is a process by which that is reviewed, theoretically by someone who is in the know, and then authorization for that care is given. Authorization, however, prior authorization does not guarantee payment. We're also going to talk next about direct access, additionally some specific coding and billing requirements, and a little bit about the time frame for clean claims. Now we're going to go back and kind of review a couple of these. The first one, direct access. I happen to live in Michigan. Michigan is one of 2 states right now that does not have direct access according to the APTA. But one of my questions is, what constitutes real direct access? Is it the ability to have access to a patient, or a patient to have access to the therapist for evaluation, for consultation, or is it for actually full unencumbered treatment? If you look at the practice acts of all of the states and other territories and districts within the United States, what you'll find is that there are very, very few jurisdictions that have truly unfettered direct access. Some of them do exist. But the different requirements are as different as the 50 states, and it is necessary to really take a quick look at that and really understand your Practice Act because it will have a significant impact on you. Additionally, the ability for third-party reimbursement for direct access is incredibly sketchy at this point. There are some that do it. There are some that, but for the most part, don't do it. Now, technically, Medicare does reimburse direct access. You do not need a physician referral to evaluate a patient under Medicare unless your state requires it. And right now, only Oklahoma and Michigan do. Or if your organization, within their policies and procedures, say that all patients who are starting up physical therapy, occupational therapy, or the rehab services will require a physician referral. But Medicare allows you to do that. Their requirement for reimbursement is that your plan of care be certified by a physician, and as they define physicians. In reality, Medicare doesn't function as direct access, because by far the easiest way for a patient to get to us in a Medicare situation is to be referred by a physician. Obviously, they need to have a physician relationship in order for a certification of the plan of care to occur. So it's really not full and unfettered direct access in Medicare. But for the evaluation, Medicare guidelines do allow us to do that. In practicality, most organizations won't. Okay, we talked about enrollment a little bit earlier. We talked about the fact that it's significant administrative overhead, that there are time frame delays, and that it is a barrier to entry. And enrollment is really the steps that lead to the signing of a provider agreement, which says, I agree to do this and provide care in this way and participate with your payment organization. And in exchange, when I do this, you'll pay me this amount. But the enrollment process is also known as the credentialing process, but it can be significant. We're seeing, depending on the states, enrollment taking anywhere from a minimum of about 8 weeks for Medicare, as an example, in some cases to be as long as 120 to 150 days. That's 4 to 5 months. And that's if things go smoothly, and sometimes they do and sometimes they don't. Verification of benefits, the purpose of which we've talked about earlier, is to make sure that you understand what are the conditions to receive payment and how much that will be, and that the patient understands what their financial responsibility will be. This form that you see here is from one of my companies that's called First Choice Physical Therapy, and we call it the Therapy Benefit Sheet. And on it, we put down the patient's name, Mr. Jones. As a service to you, we have contacted your insurance carrier to determine your benefit coverage for therapy services. Your insurance coverage, for example, Aetna, has communicated to us on, for example, March 3rd. It is also important for you to be familiar with your benefits and verify the accuracy to ensure that you know what your financial responsibilities are. First, we are or are not providers for your insurance company. Secondly, they pay for what percentage of the costs of treatment. You will be responsible for approximately this amount per visit. You have a deductible of X amount, of which X amount has been met this year. Your insurance company allows X number of visits per calendar year, and other benefit limitations that we've identified are: the phone number for your insurance company is, and this information was provided to us by Mary Smith from Aetna. If you have any questions, we'll be happy to explain further. This is a letter that we actually the therapist actually gives to, or the front desk people give to the patient, so they have it in writing, and we ask them to sign it. We have 2 copies, one that they sign and give back to us, and one that they keep. This hopefully clearly articulates what is it that they have in terms of benefits. One of the things that you also have to realize is that sometimes when you contact an insurance company to verify benefits, you don't always get complete or accurate information. Prior authorization, as we mentioned earlier, is no guarantee of payment. It is still subject to retrospective review and audit. And again, this constitutes another form of administrative overhead. Let's talk a little bit about some of the specific coding and time frame requirements. For example, and these are only examples, and these are specific to the companies I'm talking about. Medicare has an 8-minute rule, which says that basically for therapeutic activities, for procedural work, a unit of service is not a unit of service until 8 minutes of that service have been delivered for codes that are timed. Additionally, Medicare requires a statement of progress every 10 visits. They have specific documentation guidelines that you need to follow. And another good example is that there is a requirement for general supervision of assistants in most settings: hospitals, home health, nursing homes, or skilled nursing facilities. But in physical therapy with private practice settings, in other words, true private practices, that requirement is not general supervision, it's direct supervision. Direct supervision means in the same suite as the assistant. These are the rules that we agree to when we sign a provider contract. These are the conditions of participation for Medicare. And then there's lots of other ones, but these are just some examples that are very specific to Medicare. Now, if your state law is more restrictive than any of these things, it will obviously supersede. Another example is in TRICARE. TRICARE does not reimburse for anything that's done by a PTA or a CODA, period. They just don't. And when you sign a provider agreement with TRICARE, as you go through the enrollment process, you agree to do that. If you're found to be using assistance to provide care, and you accept payment for it, you may have yourself some legal problems that could constitute either fraud or abuse, but you're probably going to pay some money back because you received payment for services that were outside the conditions of participation. Okay, let's talk a little bit about documents and systems. When we talk about generating revenue, it's important that we understand that we have to create some documents to do this, and we probably have to have some systems in play. We talked about these much more in the second week of this course. But first of all, the idea behind a document is to capture it all in one place, so that ideally the source of your billing data is your medical record. We're going to talk in just a second about a daily billing worksheet as an example, and then obviously we need to get into the audit process a little bit. I want to define a couple of terms here that we'll be talking about a little bit more, and you'll be working on a little bit more on your own. This is a term that's not used by many people. However, I think it's a very valuable one for our purposes, and it's called an expectable. So it's not a billable or a payable, it's an expectable. And that represents the amount that should be paid for services that's based on insurance contracts, fee schedules, or other known parameters. So for example, you can bill for 15 minutes of Therax, you can bill Medicare $1 million if you'd like. But depending on where you live, you should be able to figure out what they're going to pay you. And regardless of what you bill, as long as you bill more than the amount that they have as their allowable, you will only be paid the allowable. Expectables are not the same as charges. They're not the same as payments. They're not the same as receivables. They're really what you ought to get. And it's a number that I find very, very helpful when I really look at analysis of the financial practices of physical therapy providers. So it's a new term, and I know that a lot of folks don't use it, but I talk about expectables a lot. So that if, for example, in Michigan, if in 2014, if as a physical therapist in private practice, I spend an hour of procedural time with a Medicare patient, and I bill WPS, which is our Medicare carrier, as our MAC in this area, I expect that I'm going to get somewhere around $105, $106, maybe $107, depending on what I did. Even though I might bill $200 or $300 for that, that's a lovely number, the $200 or $300 that's billed. But what really matters to me is, what do I expect to get paid? And I expect to collect every penny of the expectable. That's one of the reasons why we call it expectable. One of your assignments for this week is to complete the expectables worksheet. And we want you to complete this for your top 2 or 3 volume payers, the ones that are most important. So they could be Medicare, they could be Blue Cross, they could be an HMO, they could be, you can pick whatever you want. But what we want you to do is, on this, identify, first of all, who the payer is, and you can, anything you want here. You can pick any ones you want, and you pick 2 or 3. And then identify, when you do a physical therapy evaluation or reevaluation in each one of these, first of all, what's the amount that gets charged out? What's the expected payment? And then I want you to do a little bit of math. What percentage of the charge is expected? So if this is, let's say you bill $50, let's say $100 for an evaluation, and the expected amount is 75, the percent of charge expected is 75%. And then here's a place for any comments. This is a helpful thing for you to know. This is hopefully not going to be seen as busy work, but I think you might find it very interesting. As we look at the charge master, and actually you'll be involved in doing a charge master worksheet also. I also want to reference the Stephen Brill article from Time Magazine that is in your assignments. This is a very, very enlightening article, and there's also some videos that feature Stephen Brill when he was actually on The Daily Show. I apologize for the language that's used on that, but I think we're all grown up enough that that's okay. Okay, so one of your assignments is the expectables worksheet. Okay. So an expectable is the payment that is expected to be paid for services rendered. It will vary by treatments given and payer. Expectables are the true statement of accounts receivable. Okay, and that's just a detail of what you're going to do. Here's an example of a daily billing worksheet, and this is one that is done as a manual form. And this is just an example of one from several years ago when we did this manually. But basically allows you to fill in where am I, what's the name of my clinic, here's the therapist, is my full name, here's the day and the date, and then what time did I do things, here's the patient's name, and then how many of each one of these did I do, and then it gets sent off. Just basically says, here is what happened. Now, a manual daily billing worksheet is just fraught with error. There's just so many things that can go wrong here, in terms of just forgetting to bill a patient, to billing one incorrectly, or to transpose numbers, or have it recopied and data entered wrong. So although these are still out there, I really would encourage you to stay away from it and get to something. This is now what we use, which is an electronic form that's generated directly from the medical record or the medical documentation. And what you can see here is that from the patient's daily note, the daily encounter was identified as this date. Here's the patient's name. Here's what happened, and it totals, and there's also an approval to bill. The therapist is identified. Okay, and this one is also, of course, redacted. Now, next week, we're going to be talking about a very important concept, something we call the life cycle of a claim. These are the 17 steps that every bill goes through, and everything has to go through in order for it to get paid. Each one of those 17 steps is pass fail. If you fail at any one of the 17 steps, you basically don't get paid. If you pass, you get to go on to the next one. One of the things that you'll often find is that as you go through this process, the question isn't why don't we get paid? The question is how do we ever get paid? One of the pieces we're going to ask you to start to play with is to identify for each one of these 17 steps who does it, how do they do it, when is it done, and how do I know it's done? If I'm the manager, how do I know each one of these is done? It's a very complex process, and so many things can go wrong. So we're going to take a look at that next week. Okay. In that, we're going to look at the initial, here in blue, the preliminary systems. And we've talked about some of those in terms of patient registration, insurance verification, treatment authorization. Also clinical treatment, which is of these 17 is just one step. We're also going to talk about documentation. We talk about coding and billing. And then the bottom part here is collections, accounts receivable, and corporate compliance. And we're going to look at this in much more detail. Okay. Another assignment that you have for this week is to complete the self-assessment on reimbursement success. There's a separate video on that I will walk you through it. And you may or may not really need to go through the entire video, and that you can probably complete this assessment on your own. Most importantly, we want you to, after you complete the self-assessment, whether it's for you or for your organization, to reflect on your responses and take a look at what are the areas that we really need to work on if we're going to be successful at reimbursement. Okay. To summarize some of the assignments, or the assignments that you have for this week, you have several videos to watch. This one is on revenue generation. There's also some very short ones on third-party payer system, the responsibility or regulatory hierarchy. There's one on payer mix and one on charge master. You're to complete some worksheets, including the self-assessment of reimbursement success, which we just talked about, a payer mix analysis, the expectable worksheet, the charge master worksheet. That's the information that we wanted to go over on generating revenue for reimbursement basics. My name is Peter Kovacsek. I look forward to working with you on this, and I wish you all the best.